Gallbladder removal does not automatically make Wegovy, which contains Semaglutide, or Zepbound, which contains Tirzepatide, unsafe for weight loss. You can often use these drugs after recovery because they do not need the gallbladder to work. The missing organ is not the main concern. Your bile ducts, pancreas, and recovery get checked before starting, restarting, or increasing treatment. Your liver still makes bile after the gallbladder is removed. The gallbladder normally stores bile and releases more when food reaches the intestine. After surgery, bile flows from the liver through the bile ducts directly into the small intestine. You can usually digest food normally, although fatty meals may trigger loose stools. These medicines mainly reduce appetite, slow food leaving the stomach, and change hunger signals in the brain. Their weight loss effect does not depend on stored bile. That is why you may feel full after a much smaller meal. Gallbladder removal does not erase every bile-related risk. Fast weight loss raises gallstone risk mainly when a gallbladder is still present. After removal, the remaining concern shifts to your bile ducts and pancreas. Weight loss trials show how often gallstone problems occurred. In adult Wegovy injection trials, gallstones occurred in 1.6% of treated patients and 0.7% receiving placebo, an inactive treatment. That was more than twice the placebo rate. Zepbound trials reported gallstones in 1.1% of treated patients and 1% receiving placebo. That difference was very small. After removal, your operation history and current symptoms matter more than these overall trial averages. Your operation history explains why the gallbladder was removed. Removal for simple gallstones differs from removal after a blocked bile duct, pancreatic inflammation, or a surgical complication. Your records show whether the original problem was limited to the gallbladder or extended into the bile ducts or pancreas. Current symptoms show whether trouble may still be active. A past bile duct procedure or hospital stay makes those records especially useful. The surgery date can mislead you. A procedure years ago does not make new jaundice, fever, or recurring upper abdominal pain harmless. If they appear now, they get evaluated instead of dismissed just because surgery happened years ago. Recent surgery creates a different problem. New fever, worsening incision pain, abdominal swelling, or inability to keep food down may signal a surgical complication. Those problems need assessment before adding or increasing a medicine that can also cause nausea or diarrhea. Stones can remain in the common bile duct, the tube carrying bile from your liver toward the intestine. New stones may also form inside that duct after gallbladder removal. Either problem can block bile even though your gallbladder is gone. A blocked duct can cause infection, jaundice, or pancreatitis, which means inflammation of the pancreas. The pancreatic duct and bile duct meet near the small intestine. A blockage there can irritate your pancreas and produce severe upper abdominal pain. Even after you recover, the dangerous mistake is assuming every abdominal symptom comes from the injection. The location, severity, and duration of your pain help distinguish these problems. The missing gallbladder can create false reassurance. A serious blockage or pancreatic inflammation can still happen after surgery and initially look like a medication side effect. Severe or constant upper abdominal pain needs prompt assessment, especially when it reaches your back. Fever, yellow eyes, dark urine, pale stools, or repeated vomiting also raise concern. These are not typical mild dose increase symptoms. Typical medication effects are more likely to cause general nausea, fullness, belching, constipation, or diarrhea. They often begin after you start treatment or raise the dose. They do not usually cause jaundice or severe pain fixed in one area. Diarrhea creates the most confusing overlap. After gallbladder removal, bile flows continuously, and a greasy meal may still trigger urgent stools. These medicines can also cause diarrhea, especially during dose increases. The timing offers a clue, but both causes can overlap. Greasy meals make bile-related diarrhea more likely, while a recent dose increase makes medication-related diarrhea more likely. Whichever cause is driving it, fluid loss deserves the same attention as the diarrhea itself. Loose stools, vomiting, and reduced drinking can combine before strong thirst appears. Dry mouth, dizziness, very dark urine, or reduced urination suggest that fluid loss is becoming important. Bilirubin and liver enzymes, blood markers that can rise when bile flow is blocked, may get checked. Lipase is a blood marker that often rises with pancreatic inflammation. A special magnetic resonance scan that creates detailed pictures of your bile ducts may also get ordered. When you have concerning symptoms, those tests help identify a blockage or pancreatic inflammation. For routine treatment decisions, why surgery occurred, whether recovery is complete, and whether warning signs are present matter most. Your treatment plan depends on which of three practical situations fits you. The first applies after full recovery when you have no ongoing symptoms. The second applies during recent recovery or unresolved digestive trouble. The third applies if you have a history of duct blockage, pancreatitis, or repeated upper abdominal attacks. When warning signs or incomplete recovery are present, routine dose changes get paused until the problem is evaluated first. If the first situation applies, your symptoms, records, and current medicines get reviewed before starting or continuing treatment. If you are starting, the standard starting dose applies. If you are continuing without a long break, the planned schedule continues. New nausea or diarrhea may delay a dose increase. Poor intake or recurring pain should be assessed before the next increase. If the second situation applies, treatment waits until you are stable before starting, restarting, or increasing. Eating very little, vomiting, or watery stools can make the medicine harder to tolerate. Some pain medicines can worsen nausea or constipation. Drinking normally, keeping food down, and having bowel symptoms close to normal for you are the goals before moving forward. Starting too soon can make it hard to separate recovery symptoms from medication effects. If the third situation applies, whether your previous problem involved the bile ducts or pancreas gets reviewed. A history of gallstone pancreatitis makes your old records and any recurring symptoms especially important. Your records may show whether stones entered the common bile duct. They may also document a camera-guided procedure that uses X-rays and small tools to remove a duct stone. Those records show whether the problem was fully treated or still needs follow-up. Whichever situation applies to you, missed doses change the calculation. If treatment remains appropriate after several missed weeks, a lower restart dose may be needed. A long break can reduce your tolerance for the previous dose. This matters most when nausea, vomiting, or poor intake cause the interruption. Your dose is only one part of how well you tolerate treatment. You do not need to avoid all fat forever. Large fried meals, creamy sauces, and fatty meat can trigger cramping or diarrhea after surgery. Smaller, moderate fat meals are often easier when surgery-related diarrhea overlaps with medication-related fullness or nausea. After full recovery, Wegovy or Zepbound can remain an option even without a gallbladder. Before treatment starts or resumes, why surgery occurred and whether warning symptoms are present now both matter. After a long break, a lower restart dose may be the safer choice. Severe pain, jaundice, fever, or repeated vomiting always come first, ahead of any dose decision. Your bile ducts still matter. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.